Great.
Yes. Yeah.
And we have like many eminent faculties with us. And we are most fortunate to have Rajesh Simon, who is like a close friend of us all, and he's also the president of the Indian Foot and Ankle Society, and to chair the session. And the faculty we have are Nikhil Joseph Martin from Todupuzha, who will be talking to us about clinical and radiological evaluation of ligamentous instabilities of the ankle, which is and then we have Ajoy from Ramaya Medical College, who will be talking to us, about the conservative and open treatment of ATFL injuries. And then Abhishek Kini will be joining us from Mumbai, and he'll be talking about Arthrobrostrom. I guess that's like a keyhole procedure to. So anyway, the instabilities of ankle, something like everyone, most of us see such a lot of cases every day in our day clinical practice. We know the basic management about it, but we don't know the cutting edge technology of what's going on there, about which I'm sure these three eminent speakers and Rajesh to chair would like guide us and enlighten us about what's new and what has changed from the traditional teaching of ankle. Over to you, Rajesh and Sujit. You want to add something?
Yeah, that'll be wonderful. Thank you, Dr. Rajesh, for taking this up. And you got a wonderful panel here. Let's all wait for your wonderful delivery. Thank you.
Thank you, President and Secretary. It's been an honor for us to come into this ask when everybody talks about shoulder, knees, and to some extent hips. Foot and ankle always has been a backseat, especially in India. But then I think more and more people, as Dr. Schiller was saying, understanding the ankle pathology. So today we are talking about ankle instabilities, and it's all about the ankle sprain. So ankle instability is more focused on the lateral side of the ankle problem, not the medial side, because the deltoid is a very strong ligament. Nothing much happens, and it is usually the ankle, the lateral side, which gets injured. So we'll be more focused on the ankle lateral side. And we're fortunate enough to have today one of the great faculties we have in India. One is our own Nikhil. He's our golden boy. Wherever he goes, he gets some gold medals and comes back. So I call him the golden boy of Kerala. And he's got a special interest in foot and ankle. He's joined us in a lot of other places. So Nikhil will start with the thing with the basics. Ajoy is the past secretary of Indian Foot and Ankle Society and a very eminent faculty in India. He is the professor, clinical professor in Ramaya, and most of our foot and ankle cadaveric workshop is handled by Ajoy. So it's great to have you, Ajoy. And Abhishek Kini is our sports person, the Anant Joshi of foot and ankle, actually. He is now, you can say, Dinshaw Pardiwala of foot and ankle. So we have Abhishek Kini, who does a lot of arthrobrostrom. Arthrobrostrom is the brostrom gold, which is the ankle ligament repair through arthroscopy. So he will be talking on that specific thing. So I will not take further time. Over to you, Nikhil, for introducing us to the ligamentous injury.
Good evening, sir. So thank you, sir, for those kind words. I would like to thank the organizers of AASK, Schiller sir and Sujit sir, and also Rajesh sir for giving me the opportunity to be a speaker on this topic on lateral ankle instabilities. So I will be talking about clinical and radiological evaluation of ankle instabilities. So the objectives of my talk would be to speak about the definition, epidemiology, anatomy and biomechanics, mechanism of injury and predisposing factors, clinical assessments, classification and investigations. Of course, management and Arthrobrostrom will be covered by the other two speakers. So, chronic ankle instability refers to a repetitive episodes of instability which results in recurrent ankle sprains. This is one of the most commonest sports injury which we see in our daily OPD practice. 85% of which involves the lateral ankle complex, and usually the mechanism of injury is usually inversion and plantar flexion injury. 80% of the conditions heal with conservative management, and 20% have a residual symptoms, which comes to us back later with the symptoms. So I would like to share your attention to this particular slide. We've got two stabilizers of the ankle, which is passive and dynamic. The passive stabilizers are formed by the contour of the articular surface of talus and tibia with the help of integrity of the adjacent ligaments, joint capsule, retinacular tissue, and the tendon sheath. Whereas the dynamic stabilizers are by the long extensors, flexors, and the peroneal tendons, which traverses the joint, also the gravitational force and the ground reaction force while standing. I would like to bring your attention to this frostum or the truncated cone, where in extreme dorsiflex, this is actually represents the shape of a talus. So now, when in extreme dorsiflexion, the talus is at its most stable position, and the talus covers a area, has got a wider area. So also along with the passive stabilizer, it gives good amount of stability. When it flexes forward, the cone is narrower, along with which the volume decreases and becomes highly unstable. Added to this, there are 3 radii of curvature with 6 degrees of motions, which happens in the sliding and rotating and tilting motion. So coming to a bit of anatomy, we've got 3 important anatomical structures, which are the anterior talofibular ligament, the calcaneofibular ligament, and the posterior talofibular ligament. A bit of anterior talofibular ligament, it is usually closely associated with the capsule. It's usually attaches from the tip of the fibula and inserts into the talus at the not in the articular surface. This is more of a intra-articular structure, which usually have 2 bands, superior and inferior band. This prevents the anterior translation and inversion on stretch in plantar flexion. It has got the lowest maximal load to failure. The calcaneofibular ligament, it is deeper to the peroneal tendons, and it prevents supination of ankle and subtalar joint, and it is orthogonal in shape to ATFL, and it gets stretched on dorsiflexion. The posterior talofibular ligament rarely gets sprained unless and until it gets dislocated. It is more of a transverse band. It is usually seen distal to a fibula to lateral posterior talar process. This is transverse in orientation. So why is this important? Now, why biomechanics is important? Because the position of the subtalar joint is very critical to the biomechanics of the hindfoot. So the first point of contact determines the effect of the gravitational reaction force. So we know that the lateral or the medial to the when the force becomes lateral or medial to the mechanical axis, this increases the lever arm, and the everters fail when the lever arm is more than 3 to 4 centimeters. So as I said before, the mechanism of injury is basically initial contact on a plantar flex with an inverted foot, with excessive supination of the rear foot about an externally rotated leg. Here, the first structure to get torn is the ATFL, because CFL has got a higher strength, and it has got a higher load to failure than the ATFL. As I mentioned before, the PTFL is rarely torn unless and until there's a dislocation. The most common grading system which we use in ankle sprain is the Chapman classification, where it is divided into grade 1, 2, 3. So in grade 1, usually there is a microscopic stretch or tear happening. In grade 2, there's a partial tear of the ATFL, but the CFL remains intact. In grade 3, there's a complete rupture of both ATFL and CFL. Any injuries more than 6 months with recurrent sprains or giving away persisting for more than 6 months is labeled as a chronic ligamentous instability. So the theory on chronic lateral instability, there are two terms which we need to know about the instability, which is called the mechanical instability and the functional instability. This was actually defined or coined by Freeman. So what he had, mechanical instability is defined as something demonstrable ligamental laxity, both physically and radiological examination using the anterior drawer test or the talar drill test. So he had described this as any ankle motion beyond the physiological limit of the ankle in the ankle range of motion. Whereas the functional instability is the presence of symptoms of giving way without clinical or radiological signs of laxity. So this is more of a subjective feeling of ankle instability due to proprioception or neuromuscular deficit. So if you see the picture, you can see there's a combination of factors, both mechanical and functional instability to a varying degree. Some might be painless and some might be painful. So coming to pseudo instability, so there are pseudo instability are the instability which is not per se due to the ligamentous injuries. It is due to the underlying pathologies in the hindfoot, which usually precipitates the instability. So usually the commonest pathologies are peroneal tendons pathologies or ankle synovitis, probably due to secondary rheumatoid arthritis. So few others are loose bodies, OCDs of talus, or anterior impingement lesions, or occult fractures, especially lateral talar process or fifth metatarsal base fracture. So the most important point over here is the subtalar joint is most important in the ankle instability. So normally when heel strike, a torque at the subtalar joint axis due to a heel valgus and ankle dorsiflexion protects the lateral structures. So any presence of varus deformity at the subtalar joint leads to, or ankle equinus, leads to increases the risk of injury. So coming to history taking, it is the most important part of the examination. So as we all know, so the time period and the mechanism of injury gives us some amount of information. If a patient gives us information of a eversion kind of injury, probably most probable injured structure could be a deltoid ligament. Whereas in inversion injury, most probable injured structure could be a lateral ligamentous complex. Then the nature of the person, where he's a professional athlete or just a social person. The symptoms where the patient comes with pain, instability, or recurrent sprains, feeling of giving away, or recurrent swelling. Then the number of episodes, whether it's the first time or multiple episodes, the frequency or impact of activities, how the patient is able to adapt to the activities of daily living or sport activities, and what all interventions he has undergone through the entire treatment. So where first, what kind of physiotherapy is undergone, any footwear correction or orthotics he was prescribed, any kind of surgery, and especially last but not the least, history of hypermobility, ligamentous laxity needs to be checked. Coming to clinical examination, as we all been taught in our undergraduate dates, it is described as look, feel, and move. So first, the foot should be exposed to the knee. Look for the external injuries, any swelling, ecchymosis. Look for the obvious deformities, both from the posterior, from the side, from the anterior. So look for any cavus deformity or pes planus. Look at the gait pattern and also look at the hyperlaxity with the help of Baton's criteria. On palpation, look for the areas of tenderness. Examine the subtalar joint, the peroneals, the triceps surae, the gastrosoleus muscle tightness with Silversky or KS, the subtalar syndesmotic joint and subtalar ligament, and also impingement test, squeeze test, and anterior drawer test, which are the part of stress tests which are mentioned. So it is important to keep few conditions in our mind when you examine the ankle joint. If the patient has clinically tenderness on the lateral midfoot, be aware that possibility of a fifth metatarsal base fracture. If there's a tenderness on the lateral ankle joint with a squeeze test positive, Always think about a syndesmotic injury. Tenderness on the proximal fibula, suggestive of a Messinier fracture. Tenderness over the sinus tarsi. Keep in mind anterior process calcaneus fracture. Or a foot swelling with plantar ecchymosis. Think about a Lisfranc fracture. So few tests which are usually described and which are useful in our clinic. So first would be an impingement test where we hold our hand behind the calcaneus and one hand on the forefoot, and the thumb is palpated on the anterolateral part of the talocrural joint. Initially, the foot is kept in plantar flexion, slowly dorsiflex with eversion, and indicate when this particular maneuver is done. If there is a pain, this is indicative of a positive test for an impingement. Second test would be a varus stress test or talar tilt test. This can be done in 3 components where we can assess both ATFL, CFL as well as PTFL. So where we keep the patient in knee hanging position. Foot initially for ATFL, usually the foot is kept in plantar flexion. Hold the calcaneus, and on inversion, if it replicates pain, that is a positive test. Keeping the foot in 90-degree perpendicular to the talus, usually what the CFL ligaments come into action. So the same maneuver is repeated. So on eversion, if there is a pain, there is a injury to the CFL ligament. On eversion, if there is pain, it is more of a deltoid ligament injury. In full dorsiflexion, inversion, eversion, if the pain is replicated, it is more of a PTFL injury. The most important test for instability, the anterior droid test, usually keeping the patient with knee inflection, foot hanging outside the examination couch, stabilize the tibia with one hand and hold the calcaneus with the other hand, and after stabilizing the ankle joint anteriorly, you pull the joint, and you can appreciate there is an instability and opening up. So this is 96% sensitive and 84% specific in this test. Always keep high ankle sprain in your mind when patients come with again ankle injury, where usually patients will complain of pain at rest, high squeeze test or dorsiflexion stress test. These are all positive for a high ankle sprain test. So clinical examination would conclude with the help of a range of motion, dorsiflexion, plantar flexion, inversion and eversion, the strength of the peroneal muscles, the dorsiflexors and the extensors, and also assess the proprioception by making the patient stand on a single leg. So Ottawa ankle rules, basically any after any injury, patients, there are 5 points in the Ottawa ankle rules. So basically when patient has the point number 1 is pain on the lateral tip of the 6 centimeters in the from the tip of the lateral malleolus 1, and the 6 centimeters on from the tip of the medial malleoli 3, base of the 5th metatarsal, 4th on the naviculum. So after the injury, if the patient is unable to weight bear, that definitely calls for an X-ray. Now usually on the lateral side 6 centimeters and the base of 5th metatarsal, usually you need to consider getting a ankle and the foot X-ray. It's same on the other side also. Now always the first choice of investigation will be a plain X-ray. Plain X-ray will, with the help of a stress X-ray, gives a lot of information about the lateral ligamentous instabilities. Even you can see a bony small osteophyte on the tip, lateral to the tip of lateral malleoli, which usually suggests some peroneal pathologies. MRI is a main confirmatory investigation of choice. It basically helps us in identifying the source of pain. It also helps us to identify any OCDs which are not obviously visible on the X-ray, and also helps us to identify the functional instability and also the pseudo instability. Ultrasound is poor sensitive and specific for any ligamentous injury. So decision making would be made after doing a detailed documented history and examination. Appropriate investigation, which is first an X-ray, MRI, which is confirmed which is further confirmed as mechanical or functional instability, and also associated pseudo instability injuries are noted. Just a word about acute injury. So the first form of treatment would be, as we all know, rest, ice, compression, and elevation. Patient, in case of painful on weight bearing, it is better to immobilize, but the concept is to mobilize the patient as early as possible post injury. So physiotherapy is very important post injury, and it is advocated to start as early as possible. Start with peroneal strengthening, proprioceptive training, which helps us to reduce the risk of re-injury. Now I'd like to hand over the stage to Dr. Ajoy and Dr. Kini for their further talk on conservative and open treatment of ATFL injury. Thank you.
Thank you, Nikhil. Wonderful talk. Before we move on to Ajoy, we have a question here from Sujit. How to properly do a varus stress X-ray traction useful along with the varus stress? Nikhil, question to you.
Yeah. So what was it?
The question was how to do a varus test by Sujit. Did you see the question? How to properly do varus stress X-ray traction useful along with the varus stress?
So varus stress test in an acute situation would be painful for the patient. So usually varus stress test in an acute situation, I don't think is advocated.
Yeah. So yes, Sujit, I'll help Nikhil in this. Yes, it is definitely painful depending upon the grading of the injury. If you have a gross instability where your anterior drawer test and everything is, full, you can actually see the patient is completely full if it is a grade 3. If it is just grade 1, grade 2, usually we do not see anything, but you just give a kind of varus strain to the ankle. You don't have to pull the ankle. You just give a varus strain and get the APV of the ankle. You really do not have to pull the ankle for that matter when you do an X-ray. But how much of sensitivity it does, or how much, how much do we really have to go for a aggressive treatment like a knee instability? Unlike the knee instability, ankle is not aggressively managed. So I think before I go into further answering your question, I think Ajoy will have few of the answers of that particular thing in his talk. So after that, we'll go back to your question and answer it in the whole thing. So since we don't have many other questions, over to Ajoy. But before Ajoy, you can load your talk. I'll just add on with what Nikhil has said. Ajoy, you can add. Ajoy, you can share your slides.
Shall I? Okay.
Yeah. So what I was re-emphasize on Nikhil's talk is the look, feel, and move. Inspection is extremely, extremely important in an ankle sprain, and not an investigation like an MRI, which most of us as knee or on the other side do. Here, it is more of a clinical diagnosis, which is more important. So over to you, Ajoy. Ajoy, over to you.
Yeah. Right. So that's what. So like Rajesh just emphasized, it's the clinical diagnosis that we generally rely upon. And this is one of the areas of tenderness which Nikhil had pointed to us in the images that he showed. And this is the talar tilt test which is being performed. I'll just put this on. Okay, this is the talar tilt test being performed. And we generally keep this for the chronic situation. In an acute situation, it is going to be very, very painful. So this is what we do. So this is how it is performed. It's the anterior-talofibular ligament, which is turned, and that's the calcifibular. And this is what we are going to check. There is a plantar flexion and inversion is what we are going to check in this. It is not, there's no, and if you want to image this whole thing, we can do this by means of an X-ray, which is taken, an AP X-ray. And one of the reasons, or probably one of the places where this does find a value is if you're doing intraoperatively. So I think then it is ideal to compare. If we are draped both the sides, we can compare it easily, and then we can get an idea as to how much of an instability we are dealing with, whether when we can plan our surgical treatment accordingly. So that's the tactile test, and that's the anterior drawers test, and just a small video of the anterior drawers test over here. So you can see that the plantar flexion is performed, the tibia is stabilized, the foot is held on to. So from the calcaneus, so you can see the amount of laxity which is present in this particular patient intraoperatively. And this is the same patient who post-operatively, you can see that the whole thing was quite stable. And this is the varus test of the same patient which was being performed. Since I had put in an internal brace in this patient, the whole thing had become very stiff in the initial stages, and then on I went on to mobilize him. So this is where Nikhil had left us with in the management of the acute ankle sprain, the rest eyes and crepe and elevation, and the physiotherapy that is performed soon after. So as he also told, and what I would also like to emphasize is that the focus now is more on a functional rehabilitation rather than applying a rigid immobilization for all these patients. So previously, until unless we would go with a plaster cast, which is given for the period of about 3 weeks to sometimes up to 6 weeks. And then on, after we took it out, we would find that the patient had got a lot of wasting of the muscles and all. So that is no longer performed. So there is one other thing that we do in these cases, which I will now be mentioning about. So this is about using of a semi-rigid cast immobilization for the treatment of grade 2 and grade 3 inversion injuries of the ankle. So it is found that semi-rigid casting is more beneficial because it gives that much amount of the functionality to the patient. So he's able to, I'll just show you what the cast looks like. These are some systematic reviews of the same. You could go through these whenever you would find time. And the one from Nick Van Dyke, Nick Van Dyke was here in India, as well as he had come down to Kochi for performing that live surgery. So that was it. And so he had mentioned regarding the usage of a semi-rigid immobilization compared to a rigid mobilization. This is one of the ways wherein the semi-rigid. So since that was mentioning the. So that's how it goes with. So we use this particular technique called as the heel lock technique. So it is. I'm trying to. I think I can mute it. Yeah, okay, so that's how it goes. We apply a couple of rolls, and then this is where the heel lock is being applied. You can see that I'm just pointing out that to say that that's the heel lock. So on the lateral side, we are going to apply a single cast layer, which is extending like that. So this, and then after we have done this, we are going to again use the plaster cast as the second layer. As a second layer on top of this. As the second layer on top of this, and once this is applied, you can see that the patient does have a prevention of inversion and eversion, but at the same time he's able to plantar flex and dorsiflex. So I just get the patient to do that. See there, you can see that he's able to invert and evert on this side, but not able to do it on this side. But he's got some amount of flexibility. It's not fully the movement happening at his ankle, but then they're able to mobilize themselves quite well. Inversion eversion is prevented, and they're able to walk comfortably. So this is one of the greatest advantages of this kind of a plaster cast application. It's a semi-rigid casting which is available to almost all of us. And the advantages with that is that it can even be simply cut by means of a scissors. We don't need to go and have a plaster cutter or something. So that was with regard to the initial management of these patients in an acute setting. So we are going to go with a functional treatment. We're going to go with a semi-rigid casting. And then after the semi-rigid casting, we are going to give this patient some peroneal strengthening exercises and proprioceptive exercises. The only time when this patient would require a surgery in an acute setting is if there is an avulsion, if there's a bony avulsion either from the talar side or from the fibula side, is when we can plan for an early intervention, early surgical intervention. But by and large, that is very little incidence of that, and we would always be planning for a surgery only in a chronic setting. So the most common surgery that we perform is a open procedure such as the Brostrom wounds, the incision for which I have drawn out over here. It is a semilunar shaped incision extending just in front of the lateral malleolus and going back up to the peroneal tendons over here. So by this, we are protecting both the superficial peroneal nerve, which is running along the fourth metatarsal, and the sural nerve, which is running midway between the lateral malleolus and the fibula over here. So none of the nerves are getting injured. So through this incision, and as we develop the planes down, so we are going to isolate the ligaments. The stretched out ligaments on the lateral side can be identified, and then we are going to perform like a double breasting. So I have just shown these steps here. So this is how it is going to be. You can see over here that the cuff of the ATFL is here on this side, and the talar articulus F is visible over here. So cut through the same, and then we are going to double breast it. So this is going to go underneath here, and this is going to come on top of this. So this kind of a double breasting, when it is done, is going to stabilize the ankle quite well. So this is what is going to be done, and you can see how the procedure is completed. A textbook, just a textbook picture here, just so that we know exactly what is being done. And that is how this is called the Gould's modification, wherein he has taken a little bit of the extensor retinaculum, which is just there adjacent to it, and is going to reinforce the repair that we have done over here. That's the Gould's modification of it. The same thing which is being shown here, and it is a completed procedure. So this is one of my own patients where I had performed it. So you can see that these are the two limbs of the ligaments which we have separated out. So this is going to go underneath over here, and this is going to come on top of this. And from here we are going to get the fibular retinaculum, extensor retinaculum, and that we are going to suture it on top over here. This is what is done, and sometimes we can even use an suture anchor in the cases where the tissue is slightly deficient, and through that we get these sutures out and use them to perform the double breasting. Associated evaluation of the syndesmosis is always required, and he was already stressing about it. So syndesmotic injuries, if they are present, these are the ones which require some amount of a rigid immobilization for some duration of time, maybe about 3 weeks. But later on, the patients are reassessed again, and if these tests, the clinical tests, turn out to be negative, then the patient goes on to a functional rehabilitation. If the tests are still positive, then he goes ahead with an MRI and try to assess with how bad the syndesmotic injury is, and then plan for a surgical intervention in these cases. So that's about it, kind of summarizing the whole thing. And, I would be open to all kinds of open up the discussion for this particular topic.
Thank you. Thank you, Ajoy, for that illustrative thing about the Brostrom Gold modification. So as he also emphasized that we as foot and ankle surgeons are quite conservative, and usually the first 6 to 8 weeks is managed conservatively. My personal basis, I do my first MRI only after 6 to 8 weeks. I would never do an MRI in the first few days. Ajoy, would you agree on that, or would you differ?
No, no difference. Exactly the same. So I, at least until the first 2 weeks, I have already immobilized this. I have already semi-rigidly immobilized these patients. I don't ask for an MRI at all. MRI indications are very clear. So after the end of 3 weeks, there is still persistent tenderness, or there's a persistent squeeze test. Only then ask for an MRI, not prior to that.
True. So the first few weeks, we do not think about anything other than conservative management, whatever the instability is. Usually, I've seen more than plus grade 2 plus kind of solving very well with just conservative management. So if you look at statistical way, 81% can be managed conservatively. Only 19% of the patients who have and the ankle instability do go for surgery. And that is why, compared to an ACL, the ATFL is rarely operated, wherein, so that is the difference between a knee and an ankle, wherein we do less than 20% of patients with having instability and surgery. There is something which probably you would have missed, because here we have a whole lot of knee people. The use of external, the internal bracing, something which all the people do. They use those fiber tapes and all that. So, what is your point about usage of the internal brace when you do? So the Brostrom bolt is an anatomical repair. It is just a double breasting of the patient's own native ATFL. When do you do add on with the internal braces to act, or do you do it alone? How do you do about it? How do you
Okay, so the usage of an internal brace is reserved for those conditions where the tissue is not very good. If I feel that the repair that I had performed was not, it's very flimsy, I feel that needs to be protected, that I keep as an indication for using of an internal brace. And in cases like what you just brought out, the presence of anatomical and non-anatomical repairs, the non-anatomical procedures such as the Christman Snooks or even the Watson-Jones, wherein we use a portion of the peroneus brevis, and so that leaving the attachment to the fifth metatarsal there. So taking only one half of the peroneus brevis, performing a tunnel through the calcaneus, through the talus, and through the fibula, and suturing the whole thing back onto itself. So this was one of the procedures which was described, and especially reserved for those indications wherein an anatomical repair did not work, or failures of the anatomical repair. So that's when we look at these non-anatomical procedures. Other procedures that we can also think of is using a free tendon graft. So you can either use a hamstring, or you can even use a plantaris. I have seen Professor Hinterman use a plantaris. So he harvests it so beautifully. And that he uses that as a check-in onto the lateral aspect. So these are the main things that I can think of.
Yeah, so Professor Hinterman is not a great this thing for internal brace, so he uses plantaris. But I think with the internal brace coming in, and the usage of the tendon has come down significantly. Do we have Abhishek? Abhishek, are you here?
Yes, sir.
Yes, Abhishek. So your views on it before we go on to your talk.
I'm not a big internal brace user. I think it's synthetic. It causes a lot of reactions, and it has a very small room for error. Like, if you keep it loose, then it is of no use. If you keep it too tight, again, it stiffens up, it restricts dorsiflexion, and patients get a lot of problem with that. So getting that normal anatomical check-in, which they claim that it does, yes, it will act, but tensioning it is in a human's hand, that is in our hands, and there are no objective methods in which you can replicate the same tension every time. So I have had patients who have been put by an internal brace, and they are either too tight or again they are feel unstable, and if they are unstable, then that synthetic component plays havoc and it creates lot of granulomatous inflammatory response in the subtalar joint, especially the sinus tarsi. And then you are dealing with a different problem all of its own. Plus, I think it gets into the picture a very important part, which is very easy to describe, but very difficult for someone who's doing it occasionally, is to get the anchor placements correct. One is on the talar neck, and other is on the fibular face. And if you are going by the internal brace technique, you have already put two anchors on the fibula to get your so-called ATFL and CFL repair, and then you're putting a third 4.5 push lock on the same footprint or slightly above, because if you put it too up, then you are actually you are causing iatrogenic dorsiflexion restriction, because you are invading into the territory of AITFL, which is just 4 millimeters above the ATFL footprint. So, I feel there are too many points where we can go wrong on this thing. It's easier to describe on a cadaver or on a sawbone, but on live patients where the face of fibula is not always flat, the live patient where there are scar tissues where are easy to slip intra-op, even if you're doing an open repair, I think it's at least I feel there are too many chances of people going wrong in it than doing it correctly. And hence, I honestly I would not advocate that, especially. So,
Abhishek, great points. I think you made it very clear about the damages which an internal brace can do. We all have kind of had very bad experience with internal brace ourselves. So this is just a point to make, because the company people do present about you can do it, and this is what the practical tips and problems we have when we do it in ankle this thing. So the proximity of AITFL, the amount of the metal of the implants inside, all that, plus the reaction. So that is a very good point. So now we'll go to your talk, Abhishek, or the Arthrobrostrom, before we go for the final discussions.
Yeah, I'll just share my screen. Okay, hi. So I'm going to talk on arthroscopic modified Brostrom repair for lateral ankle ligament instability. I'm Abhishek Kini. As we know that ankle ligament injuries are the most common acute sports injury, and almost 25% of running and jumping sport involves it. And out of these ankle injuries, 95% are ankle sprains, and they are the most common cause for absence in professional sport. As Ajoy just said, modified Brostrom Gold is the standard or gold standard till now, which is what it is. So, but we also know that almost 10 to 15% of these procedures also are not happy or have recurrent instability or have residual pain. And that opens up another chapter of are we missing out any intra-articular pathology in these? Which, lot of papers have shown that, there are intra-articular pathologies which can actually cause pain or persistent pain, like, impingement, loose bodies, osteochondral injuries, meniscoid lesions in the anterolateral gutter. So there have been shown that subsequent or adjacent or along with a Brostrom, if you could do a arthroscopic evaluation and address the intra-articular pathology, it is definitely helpful. So what are the disadvantages of doing an arthroscopy with an open Brostrom is that, the lateral gutter opens up, or the tissue becomes very mushy because of the extravasation of fluid, and that makes an open Brostrom difficult. So now what we do is we do an arthroscopic Brostrom, and in this talk we're going to talk about the indications, the techniques, and the results of our series. What are the indications? Normally an ATFL injury. To begin with, I would say start with one-sided injury, fibular side. which are non-compensating with physiotherapy. As Dr. Rajesh said, that we always put them on a good trial of physiotherapy, as ideally even a knee guy should with prehab. But we do that in ankle more often, and which are not associated with any extra articular lesions like peroneal tendon tears or a hindfoot varus, which needs a hindfoot corrective osteotomy and then the brostrom. Technique: standard 4 mm scope. The ankle is a big joint. You don't need small scopes. Regular probe graspers, punches, osteotome curettes, suture passing devices like the AccuPass. I use a 2.3 anchor on the face of fibula. Position is supine, and that's for at the edge of the table with ipsilateral buttock slightly elevated. Landmarks are your anterior joint line, distal fibula, as you can see in the picture. You also mark the extensor retinaculum. The dotted line is the superficial peroneal nerve, which try and avoid it as much as possible. In the technique, you first confirm under anesthesia whether the drawers is positive and make portals. Anteromedial is the first viewing portal. Anterolateral is critical. It should show the lateral gutter, which is easily accessible, and introduce the small joint shaver, debride the synovium. And you can see with my probe that the footprint is bare over there. Once the footprint is marked, you pass a 2.3 anchor 1 centimeter proximal to the tip, which is actually 7 millimeters below the AITFL footprint. You try and go perpendicular to the foot.
Abhishek, your pictures are all clubbed together.
Merged. I know. I think the screen is not coming back.
Yeah.
But I think the last slide is where the main, you can see the trajectory that we are going perpendicular to the footprint, and make sure that the sutures don't cross. It's just like a shoulder bank cut, where you make sure that the anchors are, the suture management is done crisply. So what is the safe zone in this? So if you look at the picture, there is a dotted line which marks the superior peroneal nerve and the distal end of fibula where the peroneal tendons are crossing. In between that zone, in between these two lines is the safe zone. And that's a good 4 to 5 centimeter area between the sural nerve, superficial peroneal nerve branch, and the peroneus brevis and the tertius. That's the safe interval through which you have to take bites. Again, sorry for this, but the bites are taken or passed perpendicular to that. It grasps the inferior, the extensor retinaculum, the capsule, and the ligament. So actually the bite includes ligamento-capsular retinacular bites. So when you take these perpendicular and you pass your sutures through them, you will get a bite of them. So, and then finally when you tie, it will all go and bunch up onto the distal end of fibula, like you do in a bank cut, like how you do the inferior capsular shift in a bank cut, which you take bites at 5 o'clock and you pull up the capsule. Similar, this is done where you pull up the capsule, retinaculum, and the ligament all together and bring it up. Final picture, on the left is ATFL deficient. On the right is how the ATFL gets reattached with the capsule and the ligament, capsule and the retinaculum. And finally, intra-op, post-op evaluation shows that there is no drawer. So this was an old paper, old study that we presented in 2016 at IAS. We had 68 patients with mean age of 26 years. We had almost follow-up of average 11 months. Timing, as normally we do, slightly delayed, 6 months. On arthroscopy, like almost like 1/3 or 1/4 or 1/3 or more than 1/3 patients had intra-articular lesions which needed addressing. So arthroscopy was justified. Mean duration of surgery for me nowadays is less, but averagely was 54 minutes. Active rehab started at 2 weeks post-op, and they could resume pre-injury level activities averagely between 4 to 6 months. My AOFS score improved from 63 to 94. I had 1 lateral cutaneous nerve hypersensitivity. But early results of arthroscopic lateral ligament procedures were poor, as were early results with arthroscopic bank cuts procedure, which were also worse than open technique. Eventually, as techniques and instrumentation improved, results are now equal or better than open techniques. So ankle results nowadays are also way better than open. As we know, enough papers which have come with 12 months follow-up in peer-reviewed papers, that literature is showing equivalent or if not better clinical results. So what have we seen? We've seen an ATFL deficient ankle, which is getting from arthroscopically reattached ATFL. We have seen that our intra-op drawers is also getting negated. So decreased post-operative time and swelling. We have faster recovery. We have better post-op cosmesis and higher patient satisfaction. So what is stopping us? To add to this, biomechanical data also, we have papers which show that arthroscopic brostrom is equivalent to an open technique. So to summarize, I think there are 4 S of arthroscopic brostrom. 1, it's safe, no major complications. 2, it's simple because there's minimal soft tissue dissection, preserves soft tissue envelope. It's stable because biomechanically and clinically equivalent, allows patient to start post-op protected rehab early. And 4th S is satisfaction. Patients are happy with those small, tiny keyhole surgeries. Actually, there is a 5th S of success, which is loading, and it's like loading quite fast. So I think I would like to sign off, are we going to live in like this era, or now we are going to live in the present and future of this era? And I think we all ankle surgeons need to take the plunge. Thank you.
Thank you, Abhishek. Let me thank you once again. I mean, he's left his daughter's birthday and is still with us. Thank you very much.
My duty, my commitment. I stand by.
Yes, so I can understand the way you're walking out and presenting your case.
Yeah, there are other kids around making noise, so I have to stay away from them.
Yes. So we again once again thank you, Ajoy and Abhishek, for those wonderful presentations. Today we all are plunging towards arthroscopic brostrom. We've always been talking about anatomical brostrom as a gold standard, but now with better technique, with better instrumentation, arthrobrostrom is coming into age. But the answer, the thing is, do not jump into surgery. It is the first is conservative management, and then is towards the surgery. So been having a few dedicated.
Can I take the question, sir? I think there was a question by Dr. Sujit Jose about tailor side avulsions. Yes, tailor side avulsions are also addressed by repairing the ligament back onto the tailor footprint. As in an ACL, there is a femoral footprint, there is a tibial footprint. ATFL also has a fibular footprint and a tailor footprint. Yes, more often than not, the fibular footprint that comes off or intrasubstance tear like an ACL, but sometimes you do get tibial avulsion, sometimes you do get femoral peel-off in ACL. Similarly, a peel-off of tailor footprint is also seen. In such cases, you need to put an anchor on the tailor footprint, which is on the margin of articular cartilage ending anteriorly and the tailor neck starting. The angle of the anchor should be pointed at 45 degrees towards the body so that you get good hold. Just like in the shoulder, you have a dead man's angle. For the tailor footprint, you have a similar 45 degrees angle for your anchor, and you can easily get the tailor footprint back onto the footprint and attach that ATFL and get your ATFL tension back. Similarly, next question is about if there is a deltoid and ATL lateral ligament injury, should you do rehab? Normally, deltoid comes with the syndesmotic, that is the high ankle ligament injury, unlike or less likely to be with lateral ligament. If it is with lateral, it would be a chronic lateral and a fresh deltoid. Normally, deltoids do heal well because it has 5 arms and has excellent blood supply. It's like the MCL of the knee. Very rarely you might need it unless it is torn and it is interposed into the medial gutter. So that you will get to know with an MRI, and once you've done that, you will know which ones to conserve and which ones to go in surgically for the deltoid. Sorry, Rajesh sir. I just thought that we'll answer the questions before we can.
Good. You did it, and you did it wonderfully. Any other questions?
One question from here.
Yeah.
So the arthrogrostrom was well explained by Dr. Abhishek, but we couldn't see the videos. it was a PDF that was projected. So that was missing. So my one concern is ankle being a very superficial joint. Would there be enough space for an acupass to move, or would you use a micro lasso or a smaller device at the ankle?
Maybe for the acupass to move in and get a bite, it is difficult. So the acupass, maybe the picture was a curved one, but you also have a straight acupass and you also have a curved acupass. So, you know, which are at 15 degrees. So they are easy to pass and they are easy to get your bites through. But if you're taking a suture lasso, which is like a curve, which you use in a bank cut, you can't do that on the ankle because you just don't have that radius of curvature to get the whole bite up there.
Yeah.
So a straight acupass is also there amongst the picture which was projected over there. I think it had all of that. I hope I answered it adequately.
Yeah. And even for a talar avulsion, would you use two anchors to?
No. So
fix
talar
it?
avulsion will have only one anchor. Honestly speaking, today the concept is that the ATFL and CFL merge on their like on the inferior fibers. So it is actually like going like a band. So if you take good bites, especially a low bite, you can also tighten or pull up the CFL along with the ATFL, and you ideally need only one anchor. That is what the most papers that are coming across and presenting. In fact, I use only one anchor. I use a one double loaded all suture anchor nowadays in my last 2 years. And my one bite is way inferior, which I try to get it and try to get some inferior capsule with hopefully CFL, but I bring it up almost like 10 millimeters up. My anchor is placed at 10 millimeters from the tip. CFL is going way down. CFL has length of 15 to like 20 millimeters. So even if I get a few bite and I pull it up, I will still tighten the CFL, which is good for me, and I will reattach the ATFL. That's how it is happening now. So with one double loaded, all suture anchors, because our fibulas are small, you really can't get that much length with those anchors.
So, I mean, just about continuing with this, how much of talus instability you find compared to the fibular detachment?
I think would be 1 in 10. If I see 10 fibula, maybe 1 talus.
Yes.
But that too is very less, very less. And the other good part about talar avulsions are that they do really well with conservative line because there's not much of movement over there. Like, you know, the fibula also contributes to your inversion, eversion, instability. But your talar avulsions are only on your anterior drawers. And while walking, actually we hardly get that much of anterior translation. So I would not be really, so talar avulsions, I may see 1 in 10, but maybe out of those one that I see, if I accumulate all 10, maybe one will come for a surgery. So, you know, the talar avulsion needing surgery is very less.
Yeah, so that's something very rarely we see a talar. I mean, I have done only one case of talar avulsion surgery, actually, to be precise. But most of us, we see fibular avulsion pretty, or fibular thing pretty commonly. Ajoy, your take on it?
Same, exactly.
Yeah, so
exactly the same.
Yeah.
Hello.
Yeah. Any serious contraindication to watch out for planning procedure? This is from Korean. After failed conservative, any serious contraindication to watch out for if planning procedures? So, contraindication for surgery. Yes, Sibin, just a minute. We just come back to you. Any serious contraindication, guys, for surgery?
I think diabetes and other things should be looked after because those are like,
so one
otherwise,
of the things which I would suggest, yes, diabetes is one. Second thing is look at the shape of the feet. If it is a cavo-varus foot, then just doing an ATFL probably is going to fail. You have to correct the cavo-varus shape of the foot. So look at the ankle instability, and if you have a cavo-varus foot, please don't jump into ATFL surgery. You might fall into problems. Anything else, guys, you would like to add on to me, Ajoy and Abhishek?
Nothing, only local issues. That's all. Any
Yes.
infections, those are like serious contraindications. But other than that, give a virus only.
Yes.
Diabetes, that's it.
Over to you.
Yeah, Dr. Abhishek, nice talk. Hello.
Thank you. Yeah, sure. Go ahead.
Just one. You just compared the technique to the Bankard's repair. No? It's just as in Bankard, we are releasing the soft tissues and then transposing it up. So is there something like you release the tissues here and then take the bite? Something.
So if there are some scarring adhesions in your gutter, lateral gutter, then you might have to release them. But normally, once you release the scars, then you can feel the ATFL nicely. There are a lot of meniscoid lesions inside, so which you might have to remove them also. So, but otherwise nothing major. Only the scarring needs to release. Nothing like, really need to release the capsule or something.
Or nothing like, no more release. Usually you get inside the joint and you take the bite. Okay. Thanks.
No, there would be a lot of scarring inside, which you might have to remove. Otherwise, nothing major.
Okay. Thank you.
That reminds me about one statement which I would like to make is most of us see a lot of ankle sprains with more of an anterolateral impingement. It is not unstable, but it is an anterolateral impingement because of the scarring in the anterolateral gutter. And a simple shaving of that anterolateral gutter would help. We don't really need patient do not really have an instability. So that is something which we'll have to differentiate between an instability and an impingement. Abhishek, your point on it. Gone. Ajoy?
Yeah, that's right. So the testing itself, the Manolase test as well as the anti-draws test, so that will help us to differentiate. So once we start off, even before we start the procedure, we know what we're dealing with. And that's like anterolateral. If it's an impingement, of course, the debridement in that area with an arthroscope would suffice. And I think it's always better to go in with an open mind, and after that, see if there's going to be an instability after we've done that. If we still feel that there is too much of an anterior translation, so something more than about 5 to 7 mm, then we can plan the two. But very rarely you need to combine the two.
Okay, so I think we've crossed our limits. Over to you, President and Secretary. Thank you, Ajoy. Thank you, Abhishek, and thank you, Nikhil, for having given wonderful talks and insights. Over to you, President and Secretary.
Yes, and good evening, Doctor. That was a wonderful session we had. Let me first thank Dr. Rajesh Simon to propagate it and arrange the talks. And the talks by Dr. Nikhil, Dr. Ajoy, Dr. Abhay were all wonderful. It gave a lot of insights into an area which is like hidden and not understood by many. Ankle sprains are just treated with bandages for many orthopedic surgeons even now. But then when an ankle injury affects the quality of play or sport in an athlete, that is when foot and ankle surgeon actually chips in and does wonders. And we could see a good array of treatment modalities, investigations. Thank you, Dr. Martin, for Dr. Nikhil for wonderfully describing the biomechanics and anatomy. Dr. Ajoy for your wonderful talk. Dr. Abhay for finding time during his kid's birthday party. I think he's gone there already. And let's hope we have more sessions on foot and ankle in our Arthroscopy Association meetings. Thank you all. Thank you all.
Thank you.
Yes, Doctor. And thank you all the delegates for joining here for this meeting.